Good afternoon, everyone. May I have your attention? It gives me a great pleasure to present our next speaker, Dr. Bassam Al-Bathi. Dr. Bassam is a consultant family physician and head of Al-Zahra Primary Care Clinic. He's an examiner in Royal College Program of General Practice in Kuwait, MRCGP International. He runs a mental health clinic and primary care center, and he's a member of Primary Mental Health Committee at Ministry of Health. He's a member of Corona Care Counseling National Program. He worked in Medical One Clinic as a CBT counselor in Kuwait. He graduated with honor from Johns Hopkins University, has master's in clinical mental health counseling, and he has a certificate of achievement for distinguished academic performance of training course of 2010 International Policy Planning and Management, USC. Dr. Bassam is very well known for his extraordinary skills of presentation, so I'm sure all of you are gonna enjoy the next presentation, inshallah. Dr. Bassam, floor is yours.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim, alhamdulillah, wa salatu wassalamu ala Rasulullah. Today, I want to talk about recharging your power. So we are talking about stress, burnout, and compassion fatigue. But before I starting this story, because I want to talk about the story of Jassim, a real story of patient, but I changed his name because of the confidentiality. But we need to hear this story. Before we talk about this story, I want to talk about one important example about your phone. If your phone is dead, you try to charge your phone as soon as possible, immediately. And you try to buy an original charger because you want a good supply for your iPhone or your phone. But on the other hand, if your mental or physical power dead, then unfortunately, usually we use unhelpful tools to charge our power, like unhealthy food, isolating ourselves from the society or our life, addicting to our phones, cutting out our hobbies. So today, we need to elaborate more how to charge our power in a very professional way. So my story is about Jassim. Jassim, when he was a child, everyone has a dream. And his parents asking him, what is your passion? What is your goal? He said, I want to be a doctor. I want to help people. I want to be a superhero. I want to have a good income. And here in Kuwait, if you are planning to be a doctor, your job will be immediately fulfilled. So all these dreams happened everywhere in every house. Then when he started his high school, the stress level increased, and all the house is stressed, stressed because of his studying and his passion and his overwork. Then in School of Medicine, the level of stress increased more. And now his parents didn't recognize that he had something in his personality and genetics, making him vulnerable to stress and burnout and mental disorders like anxiety and depression. But when he graduated from School of Medicine, then he feels comforted and feel happy, and he's having lots of plans. So he went to the tailor, have a nice suit, and have a new equipment for the office, and also have a new stamp, and he buy a car, and he is planning to get married. So he's very happy because he have 1 year of training, or like احنا نقول سنة الامتياز. This year is honeymoon for the doctors. He's planning to engage in a family medicine board. Now he's accepted in family medicine board. Now he faced the real work, the reality. He's working in a busy clinic, demanding population and complaining population, as well as there is a requirement for the board, requirement for studying, and also he is a new husband. He's a new father. He has a baby, and this baby crying at night, and he cannot sleep. So there is lots of stressors everywhere. Now the stress level is very high. He came to me and complaining from stress, and this stress reached the level of burnout, and I afraid that he reached the compassion fatigue. So what is the difference between those three? Stress, there is over-engagement, overactive, he's urgent, and also he lost his energy, but he has a compassion. And also he's overthinking about the work and family and everything, studying. So he cannot relax in the work, but he can relax in his house. So this damage need a recharge, just tools, lifestyle, tools and the skills. But when he reached the burnout level, the burnout now, he turned from anxiety to depression. Now he's disengaged, blunted, hopelessness, loss of hope, detached and depressed, and he cannot relax even at his home. So he need a therapy. He need a psychotherapy now, not just advices, but psychotherapy. I'm afraid that if there is no involvement of the psychotherapy, he will reach the compassion fatigue, which is life dissatisfaction. And I saw some residents told me that I'm not interested in anything. The life is meaningless. And now that the work is trauma, so he's complaining from post-traumatic stress disorder, because he's not satisfied either with work or home or life. Now, maybe he needed treatment, tablets, beside the psychotherapy. So, at the assessment stage, I assessed his physical, emotional, and behavioral issues. He's complaining from lots of complaints. Now he's having tension headache, migraines, muscle pain, GI symptoms. Also, he has some sexual dysfunction or intimate relationship problem. Also, he has essential tremors sometimes. And also, he's grinding his teeth at night, and also he has some memory and concentration problem. Emotionally, always he's agitated, always he's angry, and also irritable at home. Even his wife complaining from this. Emotionally exhaustion, he cannot also elaborate his emotions, and also there is a depersonalization. Behaviorally, he's isolated now. He cut down all his activities, even his friends. He's not engaged in anything. He used to play football or soccer 2 times a week. Now he's not playing. He's now procrastinating all his plans because there is noise in his head. Also, he's using some drugs or supplements like melatonin. He's taking Panadol night. Sometimes he's taking any drugs, illegal drugs, here and there, because he wants to feel okay. Now, before I start with him the session, I have to see why he's complaining all of this. Is it the problem with the personality? Is it because the professional isolation, because he's concentrating on the profession and now he's isolating himself from the environment? Difficult population, long hours working. Also, he's not taking what he gives. So he's giving, but there is no appreciation. So he's feeling that there is despair, ambiguous success. It's that his goal is not clear. He has no vision. He wants to be in the board, but why you are taking this board? Why you are taking this specialty? What is your vision? Sometimes you have a vision, you have a goal, but while you are walking in this journey, you lose yourself. And you have to remind yourself every time the meaning of life and the meaning of your journey. So, I use the DBT concept, dialectical behavioral therapy, which is called the chain analysis. I started with the vulnerabilities, then triggers, thoughts, emotions, and behavior. Starting with the vulnerabilities, this means that what is the ground that it's accepting or causing this tiredness. I always have this example. If you are not sleeping well, and then there is a small problem, anyone who talk in front of you, tell you some, triggered you in a negative way, your response will be different than if you are comfortable and then listen to the same trigger. So this is called vulnerabilities. Underlying vulnerabilities are aspects of the self or environment that make the negative behavior risky. So, for example, not sleeping well, not eating healthy food, not having any hobbies, and you are sick, physically sick, you are not treating your physical well. So I have to do all the investigations, lab investigation, I have to solve all the issues, and also taking him back to his life. So disease, lifestyle, relationship, personal issues should be solved. Then, when we talk about triggers, I use the existential theory that talks about if you have triggers, either you can change it or you cannot change it. Now you are in the board, and you are in one of the areas that it's crowded area, and it's different than other centers. Either you accept or you feel that you have to search for the power to change this environment, and it's difficult. So the better way is to accept that your situation now is challenging, and then you have to go to the next level, which is commitment, الالتزام. Commitment means that you have to live and search for the alternatives, for the choices you have. So if you are in a difficult center, what are the choices and alternatives available to feel good? So احنا نقول عندنا بالقرآن فعسى أن تكرهوا شيئا ويجعل الله فيه خيرا كثيرا. If you hate something, there is many goods inside it. So search for alternatives and accept. The main problem for the stress is you are not accepting the situation. Accepting not meaning that you are not searching for better, but accepting the challenge and then search for better. So when we go to thoughts, Jassim have some irrational beliefs and some errors that makes the situation worse. Black and white, because he's not accepting any mistakes, either from the patient, either from the board, either from the trainer, either from himself. So he's not accepting the mistakes. He's a perfectionist. So this is one of the mistakes. The other thing is catastrophizing. What will happen after that? Is my future is good, or I will be a bad doctor? Magnification and minimizing means that always I'm magnifying the negative part in my life. And I have lots of positive things in my life, but I'm not concentrating on it. Comparison, and this is the main problem. ليش زملائي في المراكز الثانية قاعد يصير عندهم كذا وكذا وأنا ما يصير عندي؟ ليش أنا زملائي قاعد يصير عندهم كذا؟ Why there is good opportunities with my friends, with my colleagues, and then he compare himself with others and just concentrate on negative things. Labeling. أنا وين ما أطقها عوية، هذه دائما الكلمة نقولها. I'm always failure. Nobody will like me. So this is a label. This work is disaster. Family medicine is not worth it. And all these labels make his job harder. I should study in this way. My exam should be in that way. So always using I should, and lastly, emotional reasoning. Following the gut, not following the facts. So how we challenge this? By facts. We have to challenge this by facts, by evidence. We have to use the evidence. Then we went to the emotions. What is your emotion? For example, if he's afraid from, he's terrified or overwhelmed, we have to go deep. What is the deeper feelings? So he's anxious. So what is the deeper feelings more? We go to fear. So you are afraid. Why you are afraid? And then we have to go to these categories. First, you have to identify your feelings. You have to be aware about your feelings. What is your feelings? Are you afraid? Are you sad? Are you angry? And then you have to accept. And acceptance, I will show you a video now. What is the acceptance of your feelings? Acceptance of your feelings that you don't have to blame yourself. أنا اللي غلطان سويت كذي. أنا المفروض ما أحس هذا الإحساس. Don't blame yourself. Self-blaming is like if there is a child and crying and coming to you. Before you ask him who did this for you, you have to have an empathy and compassion and validation. So there should be compassion and empathy, and you should express your feelings, either for colleagues, either for wife. So Jassim should talk with his wife, talk with his friends, talk with his trainer, and talk with his colleagues. He should talk. And the studies shows that the main solution for marriage problems is attentive listening. Attentive listening is one of the good solutions for the conflicts between parents. So this video is a test for you. Who is the person winner? There is two persons now dealing with this situation. This elephant have an emotional issue now, and there is two persons will deal with them.
My rocket! Wait, Riley and I were still using that rocket. It still has some song power left. Who is your friend who likes to play? No, you can't take my rocket to the top. Riley and I are going to the moon. Riley can't be done with me.
Hey, it's gonna be okay. We can fix this. We just need to get back to headquarters. Which way to the train station?
I had a whole trip planned for us.
Hey, who's ticklish, huh? Here comes the tickle monster.
I'm sorry they took your rocket. They took something that you loved. It's gone. Forever.
Sadness. Don't make him feel worse.
Sorry.
It's all I had left of Riley.
I bet you and Riley had great adventures.
Oh, they were wonderful. Once we flew back in time. We had breakfast twice that day.
Sadness!
It sounds amazing. I bet Riley liked it.
Oh, she did. We were best friends.
Yeah, it's sad.
I'm okay now.
من اللي فاز? Who's the winner? Sad. Why? Listening, empathy, validation, compassion. مو كل مرة نقول لا ماكو إلا العافية ويلا شد حيلك وقوم وماكو شيء. We have to listen, we have to validate, and we have to express our feelings. This is what we need. If you have a problem and struggle in your work, you should elaborate your feelings, and there should be someone to listen. This is a message not for the patient, also for the staff. So these are the last thing is behavior, and this is the wheel of life. Usually we stuck on the career, work, but when we go to other issues like spirituality, physical wellness, psychological, emotional, professional, and personal, our wheel is not balanced, so we cannot move. So when we use this, there is an hadith. Our Prophet said, إن لنفسك عليك حقا ولربك عليك حقا ولضيفك عليك حقا وإن لأهلك عليك حقا فأعط كل ذي حق حقه. You have to give everything full attention, like giving family, friends, health, hobbies, spirituality, and all of them should be 9 to 10. If your wheel is not balanced, then you will have burnout, stress, and you will have compassion fatigue. How to fulfill these goals? You have to use, Jasim should use the SMART goal. His goal should be specific, measurable. Like, for example, he decided to walk 15 minutes. It's very good. Specific, measurable, attainable, relevant to him, and also it's time. So every day he should walk 15 minutes. And I told him, be aware about the Parkinson law. What is the problem with Parkinson law? If he said, I want to study like cardiovascular chapter, in 1 month, he will finish it in 1 month. If he said, I will study cardiovascular in 1 week, he will finish it in 1 week. Because the time will extend and stretch for your goal. So you have to put a specific time to finish everything. Otherwise, you will be overwhelmed. And this is a study between two groups of students. They gave them a maze, and the difference between the two mazes is that the first one, there is a mouse and there is an owl. And they told the participants to take this mouse out of the maze. The other group, there is also a maze and there is a mouse, but there is a cheese. So the first group and the second group have the same task, but who's the group finished quickly? The cheese. Why? Because the motivation is love, is happiness. There is a goal. But on the other hand, the motivation is fear. So if he has a goal with fear of failure and fear of not reaching this goal, then he will have a struggle. And his decision will be not clear or clouded. So my tips is, he should have a professional detachment. اللي بالشغل يختلف عن حياتك. Keep your passion and a sense of perspective. Learn to forgive yourself and don't blame yourself. Look after yourself and take a break. Maintain an active and healthy lifestyle and engage with your peers. Lastly, we all in our community, even especially in Gulf area, we have something called human giver syndrome. We always have a meaning of life because we need to fulfill the giving. We need to give all the needs, giving for the needs of others. So we are not happy, we are not calm, we are not satisfied with our life until we fulfill the needs of others. So my advice is that if your charger or your charge is dead, you cannot give others. So you have to charge yourself first to charge others' life. Thank you very much.
Thank you, Dr. Bassam, for such an inspiring talk. Okay, we have a question here. With all due respect, fear is the best motivator. What's your opinion?
This is the same question of what is the difference between normal anxiety and bad anxiety. If the normal anxiety leading to more studying, more performance, more work, and you fulfill your goals, this is a good anxiety, good fear, good worries. But if this worries affecting your life, احنا نسميها جودة الحياة, affecting your life, and now you are complaining physically, mentally, emotionally, this is bad.
Thank you for your talk. This might sound harsh, but life is tough. Do you believe that over-diagnosing burnout runs the risk of creating a fragile workplace which breaks at the slightest pressure, preventing growth through overcoming challenges?
This question is a very good question, that what is the standard for burnout? In my opinion, that when the patient or a doctor or resident start to complain, we have to accept that. So it's different between person to person. There is a personality or a type of person that have attitude that it's not complaining and it's not affecting his life. And he's burning out, but he's happy. So if there is a complaint, we have to listen and we have to deal with it.
Actually, we reached the end of our questions. We thank you again, Dr. Bassam. We will welcome Dr. Dalia to give you a certificate of appreciation.
We'd like to welcome our next speaker, Dr. Fajr Saleh Al-Barrak. Dr. Fajr is a consultant family physician, a trainer and examiner in the Kuwait Board of Family Medicine, clinical educator in the Faculty of Medicine at Kuwait University. Dr. Fajr is also a certified tobacco treatment specialist and trainer in the University of Massachusetts and the Association for the Treatment of Tobacco Dependence. Dr. Fajr also has a special interest and advanced role in the primary mental health care and cognitive behavioral therapy. Dr. Fajr, the floor is yours.
مساء الخير عليكم جميعاً. في أحد عنده مشكلة لو تكلمت بالعربي؟ Anyone has an issue if I'll talk in Arabic? You have an issue. Okay. Okay. أول شيء السلام عليكم. What I'm going to talk about is the home service for bedridden and bedbound patients with disabilities, and the service is offered via primary healthcare services. من الأشياء المهمة as an outcome, a health outcome that we measure is life expectancy and the quality of life. And some of the clinical causes that plays a major role for this life expectancy and the quality of life is accessibility to the services. So we have a special category of people that they have some disabilities, whether it is physical, psychological, social, that makes them more housebound, and they are not accessing our services through the primary healthcare services clinic. So 2 years back, الإدارة المركزية للرعاية الصحية الأولية had a basic healthcare needs assessment for those patients. And as our role as family physicians, وفي السابق كنا 2 groups or specialities اللي يطلعون للhome visit, the physicians and nurses services. After assessing the healthcare needs, beside the physician اللي هو diagnosing, managing, preventive, anticipatory, screening, holistic approach, nursing like drug administration, الwound care, الفيدنج, كل هالأشياء, الإدارة المركزية found that there are other needs that the people need and they cannot access and reach. So they went into collaboration with the laboratory department, and we added to those offer الاحتياجات هذه like phlebotomy في البيت, like a blood test to be withdrawn after being ordered by the treating doctor and the multidisciplinary team in charge of this patient. So that was the third collaboration. Dentistry. Also, there is a primary preliminary dental assessment that could take place at home for those patients with the special needs that doesn't allow them to access the service, and the collaboration was there. Pharmacist, and the role of the pharmacist in medication reconciliation, polypharmacy, medication management, medication review, and medication cards, that was added as part of home care services. Dietitians, and they went through special training program under the umbrella of إدارتهم, and they became ready for the special need patients and geriatric patients that are homebound and need special care regarding their diet habits, whether له علاقة some problems, whether on NGT, PEG tube, swallowing problems, soft diet, hard diet, chronic kidney disease that they need special diet, whatever, the clinical dietitians are there. Finally, that has been added, ونفس ما انطرح البارحة بعد الكوفيد, vaccinations, whether إذا كانت seasonal vaccinations or the other geriatric vaccinations. بعدها الإدارة المركزية launched the service of home health care services تقريباً in the mid of May 2022, and that was announced, or they had a benchmark في موقع وزارة الصحة that this service could be requested via 2 pathways, either through the MOH website وطلب زيارة منزلية, and by requesting this home visit there is an automated consent form given for the staff to do the home visit, or they can do it if they face any difficulty, especially for the elderly patients. If they face difficulty to ask or request via منصة وزارة الصحة. they are free to come to the health center and ask for it بشرط أن there is a consent form should be filled to give us the right to access the home, and we offer the services needed. Even after offering all those services, we're at the level of primary healthcare centers and primary healthcare sectors that we work with them on daily basis. There was another health assessment, need assessment, and service evaluation that has been done by the same idara, and they found that those patients have special needs for other services that could be offered by the secondary and the tertiary care. Majority of our patients needs physiotherapy. And this physiotherapy, as you all know, what is the role of physiotherapy? نقلل الفرايلتي, we maintain the muscle bulk, بعد prolonged stay في المستشفى post discharge, bed bound والbedridden patient, they need special physiotherapy to avoid DVTs, etc. So بدأ هني التعاون مع قسم العلاج الطبيعي. بعدها we found that there are risk of falls, there are shortage of assessing the activities of daily living and instrumental activities of daily living, and we started the collaboration with the occupational therapist to assess the safety for homes. They give their recommendation to لزيادة مأمونية البيت والبيئة للمريض، لأن as we said إن majority are bed-bound, bedridden, CVA patient or whatever, and they give their recommendation on how to make the environment more safe and less risky for the patients at home. بالإضافة إلى الأسسمنت of the activity of daily living, whether they are dependent or independent, and whether they can do the instrumental activity of daily living. الأشياء البسيطة ذا هم قادرين على عملها من عدمه. Speech and swallowing also من الobstacles اللي احنا أو من المشاكل اللي قاعدة يواجهونها مرضانا في at homes، خصوصاً post CVA. They have really a problem with the speech and they have difficulty with the swallowing that leads to so many complications like aspiration, miscommunication with the others, beside the disabilities الثانية اللي تصير hearing والvision. If there is also a difficulty in the speech, I'm making my patient more disabled. So here we started the collaboration with the speech and the swallowing department to come and assess the speech to give and the swallowing risk, and to give their recommendation regarding the diet, the mode of parenteral or enteral feeding, etc. Ophthalmology. الophthalmology كان عندنا there is a specific there is a specific consideration. They have so much eye problems, so we decided to have a kind of teleconsultation in the bedside. So our family physician or our dear general practitioners, they go and do the home visit. They assess upon the complaint the patient has, and there is a ضابط اتصال لكل مجموعة من المناطق الصحية والمستوصفات، يتم التواصل معه، تقييم الحالة on the site, and then we decide together whether it is an emergency case and it needs to be referred via ambulance, or مثلا لا والله it's a cold case, we need to arrange for him this appointment, نرتب له الإسعاف يروح في اليوم الفلاني في الوقت الفلاني وما يتعطل ولا تتأخر الخدمة عنا في مستشفى حسب المستشفى اللي هو تابع له. Also part of our ethical commitment and our code of ethics for we all have the right to live our last days بحياتنا at home. And also يعني بعد عمر طويل everyone dies peacefully, no matter what the problem is. So we had a special attention to our cancer patients who are adults, 16 and above. طبعا بشرط also to be bedridden or they have some disabilities. And we had a collaboration with the palliative care department, whether it is a pain management, hiccups, confusions or delirium, constipations, all those problems, how to be managed. We had a collaboration with them and we have the protocol with them. And at the same time, in our near future, there might be a training for our family physicians for palliative care, علشان we can also offer the service. So the palliative care here is offered only for cancer terminally ill patient, but not all patients who need palliative care, not COPD, not heart failure. It is mainly for cancerous patients. Last but not least, we found also there is a special need for the patient with the tracheostomy tube. And we found so many complications بدأت تظهر لنا على التأخر في تبديل الأنبوب الشق الحنجري. Strictures, infection, granulation to unhealthy granulation tissue من التيوب. So we found that those patients need to change those tubes every 3 months. So we had a collaboration مع مجلس أقسام الأنف والأذن والحنجرة أن تقدم الرعاية هذه bedside for our patients with tracheostomy tube. كل واحد حسب recommendation مال الدكتور. Maximum every 3 months that should be done. تطلع معاهم سيارة إسعاف in case you know it's an airway. تطلع معاهم سيارة إسعاف في حال إن لا قدر الله صار في any airway compromised أو صار في أي مشكلة خلال تبديل التراكيوستومي tube. Then we have the immediate يعني الإسعاف قاعدة عند الباب, the immediate action to transfer the patient and to stabilize him مع الsetting والcrash cart اللي he might need if we need to maintain the airways. Actually, the primary health care home services في الإدارة المركزية is a continuous process. This is up to date, and we are looking forward to more collaborations with other departments to offer the best holistic approach for our geriatric population, for our bedridden and disabled patient. And by this, I've reached the end of my speech. I hope it was clear, and if there is any question, I'm there for you. Thank you.
Thank you, Dr. Fajr, for this informative lecture.
Thank you.
Actually, we have a few questions. The first question, is there a specific criteria for home visit indications in the primary health care?
Well, home visit, it's for any patient that has disability, makes him cannot leave the home, okay? Whether it is physical, psychological, or social. But in the same time, parallelly, we have mainly حق الجeriatric 65 years and above, for those who have limited mobility or fully bedbound. هم ندير لهم program كامل to offer CGA comprehensive geriatric assessment. في لهم staff كامل تم التعاون معاه. So we have 2 categories actually. The population, whoever has disability that doesn't make him come to the hospital, and at the same time we have the cases that are our كل منطقة عندها مجموعة geriatric, whether partially bound or partially immobile or fully immobile, that we give them a comprehensive geriatric assessment ونكمل لهم comprehensive care with multidisciplinary team. So there are 2 groups.
Following placing the request for home care visit,
Yes.
what do you do to validate the eligibility to the service?
Well, من ضمن الأشياء اللي مطلوبة for the eligibility of the service, there من ضمن في اللينك هذا اللي على منصة وزارة الصحة يتم رفع الطلب مع اسم المريض ومنو مقدم الطلب، بالإضافة إلى ريبورت يبين أن البيشنت has a disability that makes him cannot come to the health center. هذه أهم الأشياء اللي تعني لي أنا، whether الديسابيليتي هذه كانت حركية، نفسية، أو كانت اجتماعية. على سبيل المثال مثلا وحدة في العدة توفى زوجها وما تقدر تيجي للمستشفى. This is not a disability that تمنع, but this is a religious and a social issue مهم عندي in my culture and in my religion that I need to obey her needs خلال هالفترة. So في تقرير لازم يتم إرفاقه في الطلب يثبت أن الحالة ما تقدر تيجي المستوصف.
Thank you, Dr. Fajr,
Thank
for
you.
this great lecture.
شكرا. Thank you very much.
Thank you.
So a big thank you to our moderators, دكتورة فاطمة بوشهري. دكتورة ليال المنوفي. And thank you again to Dr. Faye Al-Aji. We'd like to welcome our moderators for the next lectures, Dr. Sara Al-Abdelhadi, Dr. Dalia Al-Mirjan, and Dr. Muna Al-Mtairi.
So we would like to present our next lecturer, Dr. May Al-Uthman. She's a senior specialist in the Yarmouk Healthcare Center, and she's the head of the Geriatric Program Committee in the Central Directorate of Primary Healthcare.
Assalamu alaikum. So today I will present as a continuation of Dr. Fajr lecture, the geriatric services in primary healthcare. So the aim of the service is to promote for healthy aging through providing services, preventive, diagnostic, therapeutic, rehabilitative services by either consultation or through the patient education. So how does this service works? It works in two ways, either in the clinic for the patients who can come to the clinic and reach it, and through home visits. The target population in the clinic, anyone above 65 years old and above, and for the home visit for any patient 65 years and above with the criteria that Dr. Fajr mentioned earlier, that the patient has condition prevents him from reaching the clinic. These services are scheduled upon appointments with a periodic follow-up. So the geriatric care is conducted by the geriatric clinic team. Those people are a medical team in the clinic, including physician, nurse, dietitian, pharmacist, and health educator. Then there is a collaboration with the other medical team in the center, including the specialized clinic like the chronic, diabetic, osteoporosis clinics, laboratory, X-ray department, and dental department. And there is the continuity of care through the referral to other facilities in the MOH, like the physiotherapy, occupational therapy, secondary care departments, preventive medicine for the vaccination, and the palliative care. The services that are covered in the geriatric clinic are therapeutic services, like uncontrolled chronic diseases, current falls, ulcers, impaired cognition, hearing, vision. There is the other preventive services like assessing the functional status for the daily activities or the instrumental daily activities, assessing the risk of fall, assessing the safety of the home environment, screening for depression, screening for any kind of disease according to the national and international protocols, medication review for the polypharmacy. Then there is the rehabilitative services by referring the patient to the specialized services, mainly the physiotherapy and occupational therapy, to maintain the resilience of the patient condition. Then there is the education, which is an important category that empowers the patient and the caregiver to be part of the treatment plan. This education, either by the awareness days, open days, or through the anticipatory care that happens every day in the clinic. So for this service to be established, there are training programs that are held. There is the physician's training program. It's a monthly held academic days for 1 year, followed by case-based discussion review courses. And there is a 1-month attachment course for the physicians in the clinic. This takes place in geriatric unit in Mubarak Hospital. For the nurses, there is a 1-week on-site training in the geriatric clinics that are run by the administration of geriatric service. Regarding the pharmacists, there are 8 lectures in a condensed course, both theoretical and applied knowledge lectures with an interactive form, followed by a 1-week attachment for each pharmacist in the geriatric unit in Mubarak Hospital. So by that, between 2022 and 2023, we trained 67 physicians, 39 pharmacists, and 97 nurses. Regarding the health education and awareness, multimedia videos and brochures were released were provided to be used by the centers and the doctors in the clinics. They are short, done by professionals with specific messages to be reached by the patient and the caregiver. There is also campaigns that we started campaign from this year and now will keep going. This year it was measuring the risk of fall in geriatrics. It was carried in most of the clinics that have the geriatric services. The used tools to assess the risk of fall was assessing the patient whether he or she is using walking aids. Does he have risk factors like medications that may cause hypotension, visual problems, or any orthopedic difficulties? And there is the tug test. So 3 tools were used, gathered all together to assess the risk of fall for those patients. 62 almost % had low risk, 20% had moderate risk, and 18.3% had high risk. Those with high risk had the priority to have appointment within short period of time to be seen and managed in the geriatric clinics, and of course the moderate and the low risk. These are some geriatric publications that are done by the committee. The comprehensive geriatric assessment, which is the patient file, and there is the toolkit that explains how to do the tests or examinations in the comprehensive geriatric assessment. There is the operational policy of how to start and run the clinic, and a common geriatric problems in primary health care. All of the useful material were gathered and put in OneDrive to keep it within reach for all of the physicians in the primary health care. As you can see, it includes physicians' educational materials like videos and lectures that were conducted, patient educational materials that they can use on their open days and in the social media, and any important circulars that are related to the geriatric services. So the committee started in 2021 with 2 clinics. In 2022, we reached 12 clinics. And in 2023, today, we reached 26 clinics that are running geriatric services. So our future plan is to establish more clinics to cover all Kuwait areas with a rate of at least 2 clinics by district annually. Today, already 26 teams are trained, are ready to launch the service in their clinics, and 16 other teams are to be trained in 2024 to start their clinics as soon as possible. We will, inshallah, establish a training course for the health educators, continue the established training courses, and focus on the applied knowledge refreshment courses for all the medical staff, and continue the screening program through the annual complaints and, as I said earlier, through the anticipatory care in the geriatric clinics. And thank you.
Thank you, Dr. May. There's a few questions that we have. And one of the questions is, do you have any collaboration with social workers, if there is anything that needs to be done for the home visit or for a geriatric population?
Yeah, for the time being, there is no collaboration, but it has been mentioned and put on the agenda.
You talked about some of the videos and materials that you had, and can you just repeat for us where can we access these videos and materials?
Okay, so there was a circular that was released by the الإدارة المركزية that it's like a QR code with a link that has all the files that is needed to be used in the clinic. As you can see here, there is a patient and caregiver awareness. The videos are there, they can reach it, and even the link is there without the QR code. We kept providing the doctors and mentioning it on a regular basis to be used. And also some of the videos are already posted in the Central District account, so they can even repost it to be used.
Okay, thank you. Thank you very much, Dr. May. Thank you.
I'll introduce now Dr. Huda Dwaysan. Dr. Huda Dwaysan is family medicine consultant. She is currently the head of Yarmouk Primary Health Care, which is recognized as the first healthy city in Kuwait by the WHO in 2015. In addition, Dr. Huda Dwaysan was the previous head of primary healthcare faculty at Kuwait Institute of Medical Specialization between 2008 and 2022. She's currently a trainer and examiner in Kuwait Family Medicine program. She'll give us a talk about electronic report and of incident report. You can start now, Dr. Huda.
Bismillah ar-Rahman ar-Rahim. Thank you very much for attending my lecture. And I'm going to talk about one of our project, quality improvement project in Yarmouk Health Center. Today, the topic that I'm going to talk about is about the electronic incidents reporting system. And that project is part of our big project in Yarmouk Health Center, which is the Streamline project. So Streamline Leadership Communication Project is one of the most important projects that was implemented in our center. And the reason why we are doing this, let me see how it's worked, this one. So because, okay, no need. So Following the Dr. Bathi lecture about the burnout and what we should do if we have a burnout in our practice, is to think and analyze the problem and try to find a solution and implement the solution. If the solution works, that's good, and if the solution did not work, that means we need to be patient and adapt to our burnout, our practice burnout. So because of the increased paperwork and the lack of the communication at Yarmouk Health Center, that is the reason why we are implementing the Streamline project. And also, in addition to the wastage of our precious time for our patients and for our training projects, so that's why we thought about the Streamline and the electronic incidents report, so as to cut down the burnout and the paperwork and the increased demand of strategic and policies and other things which are requested to do it and collect the data and prepare the reports, which will consume a lot of our efforts and our precious time, which should be given to our patient. So, what are the projects of our Streamline? First of all, we are running a log diary project, and that log diary is for our employee, which was introduced. And the reason for this is to make our employee aware about the strategy, the policies, the guidelines, and the CBD directly by looking at them in their online, so they can read it, they can answer the question if there is exam on these things, and also to understand it well, rather than to be trained only one lecture and then leave them. Usually we find out that lecturing them for once, it doesn't work as much as if it is there as a log diary, which will be tested monthly regarding this. The second project is the safety program. So we also introduced the incidents report and the safe round and the risk management also in our online or Streamline project. And it has a lot of good results, which I'm going to talk about one of them. Also, our meeting, the requests and the recommendations from our meeting also in the online, and also the staff working hours, excuse, vacations, sick leaves, all are streamlined in our project. There's also a comprehensive program for training, because we are a training center, so we are training medical students, either from the Kuwaiti faculty or from Bahrain or from the RCSI, and also we are training the elective. We are training also the pediatric board and the psychiatric board and the family medicine board, and also we are training the public health and also the pharmacy students. So we have a lot of a training program in our center, so we need to organize this and try to control it as much as we can, but we need the help of the Streamline by having this educational program through the online to for better control and observation and also management. It's not only the human resource not only the system we are taking care of, and not only the human resource that we are taking care of, but also even the non-human resource that also we are streamlining them, such as the equipment registration, maintenance, is also should be done by the nurse through the online system. And the most important now is when we implement all these things, we would like to have the data. And the data is the most important indicators for our job, whether it was done perfectly or not. So by having the Streamline, we can collect good data for our program. So what is Streamline? Streamline, you are not only giving infinite way to interact with your staff, partners, and customers, but also building an effective and efficient relationship with each of them. So if you want to streamline your work in your center, you need to follow 7 steps. I think Professor Arshad, we call him now the IT professor in our department. He is the most, he can give you a lecture about this in detail. So I told you about our project, but such as the staff registration, now streamlined, triaging the system, especially during COVID, drug dispensing also streamlined, calendar of the center, questionnaire, whether this questionnaire and for our patient or for our employee, training program all done by the online, and this training program is not only teaching them and they are recording them, but even giving us the evaluation for each candidate, so there is no bias. I mean, not because this is a good trainee or not good trainee. What are you working? So we have multi evaluators in our center. So for example, the nurse, she will put her evaluation, the doctor will put his evaluation, and the pharmacy will put his evaluation. So the trainee at the end, or the elective doctors at the end, he will got his evaluation through the online. Risk factor, the safety round, also now done through the online. And there's the questions of each department will be in application. So they just, while they are doing the round, they will see the questions, they answer the questions, and also they will register the risk factors. So at the end, you will have full information about what happened in this safety round, and also what are the risk management done, written in the online. And the last one is the risk factor, the incidence report, which I'm going to talk about. I talked about before this one. So, why we use the electronic incidence report? We found out that there is a reduction in the reporting of the incidence report by 50%. That's first thing. Second thing is that we found out that the employees are not interested in reporting the incidence report. And why they are not, they don't want to report, they don't have the culture of and they don't know the importance of reporting of the incidence report. And they always think that this is a punitive, maybe for them, the privacy of the reporting, and also what is the use of reporting? I mean, we didn't see the result of reporting, and nobody gave us a feedback about what happened when we are reporting the incidence report. For that reason, we thought of, we have to think about the incidence report in a way that we need to modify it in order to satisfy our employee and convince them to do it, and also at the same time increase the incidence of reporting. So what we have done, we need to change the culture. We need our employee to help them to address the importance of the safety, and don't be afraid of reporting. It's important to ensure the confidentiality, and also the quality improvement project should be the culture of our practice. And the most important now is we are talking about the incidence report and the importance of detecting the near miss and the miss before it happened, something dangerous happens to the employee or for the patient or for our practice. So incidence reporting electronic has been shown to be convenient for busy health care provider and staff, and that is how we got by a questionnaire to our staff. Second thing, improve incidence rate in healthcare delivery service. And also electronic approach to streamlining the use of adverse events report can be used to improve the patient safety in our department. So what are the tools we used for the quality improvement project? As usual, the BSDA, the fishbone, and the root cause analysis. So we implement this project on all our employees. The participants are all our employees working in Yarmouk Health Center, and that was from January to December 2022. And the data which was recorded, we took the same forms of the incidence report from the Ministry of Health with the same questions. We did not change anything. We just took them all and we put them online. So it comes to, when the employee will open the application, it will come by question. So he cannot go to the second question unless he will answer the first question. So that will guarantee that it will be more accurate and more complete. Not only this, when he answered the question through the online, it will be clear and it will be very well written and documented. So all the questions, even we took the permission of the quality department about having these questions in the online, and we guarantee the privacy because we are a closed system. We are not open system. I mean, they thought about it, the quality department, to distribute this, but they were afraid that if one center with another center, they will look at each other. But in our program, no, it's a closed, so nobody will look at the information inside what is going on. So what did we measure? We measure, because we are having burnout, we don't have time, there is an effort, it's not clear, it's not the number of the incidents is not well increased. So we measured the increase in the incident report first. Second thing is the complete and the accuracy of incidents report. Third, we measured the time taken from each employee to fill the reporting system. And the most important is the cost, and whether this cost is effort or the time need to be spent on writing the incidents report. So these are the steps, which I don't need to mention this for the quality improvement project, but for those who are interested, they will find it in the slide. They are in detail. So let me go for the results. So what is the result? If you can see that the line here is the number of the incidents report, and down is the month during 2022. And the one in blue is the paper incidents report. The one in orange is the electronic incidents report. So as you can see that the blue color from January to June, few number of incidents report were recorded. And once we shifted from paper to electronic, all of them, they did not use the paper incidents report. And all of them, they used the electronic. That's one. So that means for them it's more convenient to do the electronic incidents report. Second thing, see the number of the incidents report are much more, even 50% more than when they are using the paper incidents report. This is another result which shows the time needed to do the incidents report electronically or paper, and also the accuracy. So the blue bars is the one indicating the time. So if you see the time for the paper, which is the first one, you can see that it ranged until 35 minutes, while for the electronic, it took for them less than 10 minutes. So the time consumed for reporting the incidents report electronically is much better, less time than the paper. And regarding the accuracy, I'm sure we will all agree, we will all, know that whenever there is electronic recording and documentation, usually it will give you better result. And as you can see that the accuracy of the documentation raised until 94%. What about the employee satisfaction? So we ask a question. So in the electronic incidents report, there are the questions from the forms. Second thing we added in this questionnaire is what do you think about recording the incidents report by electronically. And the third thing is that while you are putting the information, it will record the time used during record. Even if you did not complete your recording and you stopped, it will stop. And then when you go back again and do it, then it will continue. So it will record exactly what time you took in order to fill in the form. And actually, this form now is available in your application, in your telephone, so you don't need to go and look for the paper for the incidents report, and sometimes it's not available. And not only this, I mean, even you can do that at home. Well, when you return back home, then you remember that you have incidents, so okay, let me fill it by my telephone. And the employee satisfaction, if you can see that the purple and the green and the red is all that's mean range from 8, 9, 10. So our employee in Yarmouk Health Center, they are all happy from electronic recording. And that is a good slide. I want to demonstrate important things. See the dentist. The dentist, before it was 0. After using the electronic, they are now 5 incidents report from them. So that is a good thing that happened, I mean, positive things in our department, because usually they are negative in their input, but now they are giving us a lot, and even now better in 2023. And the most important thing is the admin. Can you see the admin, how much? It was 1. And with electronic, they become 10. So that's mean electronic incidents report is really a solution for stop wasting our time, effort, using paper, accuracy, better documentation, and involve all the staff in our center. So, as a conclusion, at Yarmouk Primary Healthcare Center, we have documented effectiveness of the well-planned and executed quality improvement project. All steps of quality improvement project were followed with favorable outcome. Overall acceptability and improved reporting of incidents using electronic reporting system was demonstrated for you. And with the advancement of technology today, it's imperative and strongly recommended to use quality improvement project electronically to ensure patient safety and quality. Further studies into impact of better utilization of the electronic reporting of incidents on healthcare outcome is strongly recommended, and I hope the whole centers, they will do the same, and then we will share our data. So I implement my project to the quality department, but till now I didn't get any result from them for the last 1 year. But I published my paper, and then Professor Leslie from Australia, when I sent it to her, and then the week after, she called me, and she told me, excellent project, and wow project. And as a reward for you, I will publish yours the next issue. So that is a nice reward. Not only this, she said, it's really a good project. How come that I'll put you the picture of you and your team on the top of the first paper of the journal. So we have been rewarded by Australian in World Family Medicine journals, and I'm waiting for the response from Kuwait. So together, everyone achieved more. First of all, I would like to thank Dr. Rashid, because he is the IT man and he is responsible for this project. And I would like to thank Dr. Tasneem. She is the head of incidents report and recording this. And I would like to thank Dr. Dua Khalifa. She is the head of the quality improvement project. And I would like to thank also the dentist, Dr. Daniel Flay and Dr. Lulwa Al-Kandiri, because they have been involved, and also the administrative department, Ms. Hana Allahu. Thank you all for hearing me and sharing me this, and I hope this will be distributed.
Thank you, Dr. Huda. We have some questions.
Yes.
Is the form of the electronic incident report is the same format and wording as the manual form?
Same.
Exactly.
Not only this, the electronic, it will analyze it and it will score for it. automatically. So you don't need to score it by yourself. So I wish I cannot show you the data because this is privacy. But I wish you can see it how in colored and scored and very well written. It's really a good project, and I hope that Dr. Dina will start to, Dr. Dina. I hope Dr. Dina, she will distribute this idea in all centers because really that will be of a great help for all of us, and we will have good data and also improve the patient safety.
Okay, what is meant by...
But we'll not give it unless she will give us good human resource. Okay.
What is meant by accuracy of the incident reports?
Yes.
And how was the accuracy improvement between paper-based and electronic reports measured?
Big improvement. Because first of all, when you are recording electronically, it will be clear. The handwriting is better. You don't need to write now because everything, the question is there and you should put the answer. And also the accuracy that you cannot go to another question unless you solve the previous question. And I don't need to take the paper, look at it, take the information, put it again in another chart in the computer, and then analyze. It's automatically there. So it will cut my time, more accurate, and of course, you cannot, it's compulsory that you answer all the questions.
Okay. Next question, how was the electronic incident report done? Was it by application, and which application?
Yeah, application. This is our the secret of our professor, Shader Shade. So I don't know exactly. He is the one who is doing this. And if you need any help, you can go to him, but you will give us a doctor. So each advice by human resource. Allah يعافيك.
We're done now.
Thank you.
It's a pleasure for me to welcome Dr. Yasmin Yahya. She's a consultant family medicine, work in Msaad Saleh Primary Health Care. She's a trainer and examiner in Kuwait Family Medicine. She is also a member of Faculty of Primary Health Care. She has a diploma in diabetes care and education, and she also has a diploma in healthcare management and quality. Welcome, Dr. Yasmin.
Assalamu alaikum. Good afternoon, everybody. I'm really honored to be here today and by your presence, and thank you for staying till the last lecture of this long day. I hope it was fruitful for you as it was fruitful for me. My topic is about the screening opportunities in primary care and how they will impact our preventive health. So after this lecture, you'll be able to recognize the screening opportunities in primary care. We'll debrief them for you, and hopefully you have the ability to integrate those screening into the comprehensive care of your patients. This is my lecture outline. After a brief introduction and mentioning the screening programs in Kuwait, we will detail what screening opportunities are available in primary care that you can offer to your patients per each age group. So I'm sure that all of you agree that primary care is really the ideal place to offer screening. We see patients from all age groups. We follow them through their life span, and we can offer the opportunistic screening whenever the patient visits the clinic, especially that they come usually without symptoms or in the very early stages of the disease, and this is unique to primary care. We're also familiar with the explanation of the results and when to refer to specialists and what follow-up is required, so that's why our setting is really ideal for offering screening. Now, what's the relation between disease prevention and screening? This is the, let's say, the span of life between a patient being healthy and then eventually dies due to a disease. So in the first phase, he's healthy, he has no diseases. Then at the second phase, the disease starts to biologically, this is there, but he's still asymptomatic, and then becomes symptomatic, and then dies. So if we apply the levels of prevention, at this phase, the primary prevention is aiming to reduce the risk factors before the onset of disease, such as immunization and lifestyle intervention. In this second phase, here comes the secondary prevention, which the case finding, early detection of the disease. And here, the screening tests link to prevention. So screening tests that we offer are considered a secondary prevention. And the tertiary prevention here, when the patient is symptomatic, you aim to delay or prevent the progress of disease, and this is when we do chronic disease management, for example, or rehab programs. So how screening, what is screening? The definition of screening is summarized in this graph. It's a process of identifying apparently healthy people who may be at increased risk of disease or condition. And then, of course, they can be offered information and further tests to prevent the complication or the risks. Why does it matter? Why do we need to do screening? We are aiming to do early disease detection. Of course, it will be cost-effective. The amount of money that we spend on screening will save us the money that we spend on the disease when it occurs or the complication of the disease. Of course, that will result in improved quality of life, personalized health care, decreased morbidity and mortality, and you will offer peace of mind for your patients. They will be more reassured that whenever their test becomes negative. And of course, here, some of the patients, they act the opposite. Screenings makes them really anxious, and they just want to hide because they're asymptomatic and they're fine. They don't want to know that they have discover a disease. So this is a negotiation that, first of all, this aspect should be respected, and this you should negotiate with your patient. And of course, patient autonomy here is important. Any screening test should be taken with agreement with your patients. Some statistics that emphasize the importance of screening. So in Kuwait, the #1 cause of deaths is cardiovascular disease, around 40%, and followed by cancer, which is 22%. So if our screening, we aim to identify those risk factors for cardiovascular disease like obesity, diabetes, hypertension, dyslipidemia, and also some of the cancers, then we are contributing to reduction of number of deaths, definitely. And according to the Cancer and Arab World journal, which was published, or report, which was published in 2022, the most common cancers in Kuwait, so among Kuwaitis and non-Kuwaitis, for males, the #1 was colorectal cancer, the second was prostate, and the third is lung cancer. For females, #1 was breast, followed by thyroid and colorectal. And you can see most of these cancers are screened in the primary care level. Just to mention that these statistics belong, although they're published in 2022, they belong to the year 2015, so maybe now the ranking is a bit different. Another study that emphasizes the importance of screening is this study, which looked at the Kuwait National Mammogram Screening Program from 2014 and to 2019. And what is striking is that only 7.8% of the target population were tested in these 5 years. So it means more than 90% of Kuwaiti women missed to be screened for mammogram. And among those 14,000, they found around 550 to have lesions. Half of them were malignant. So again, this emphasizes our role as primary care physicians to encourage ladies to undertake the screening. What screening programs do we have in Kuwait? And of course, the screening programs that are relevant to us in primary care, we have the NCD screening for diabetes, hypertension, dyslipidemia, obesity. We have osteoporosis screening, colon cancer screening, breast cancer screening, cervical cancer screening, mental health screening, prostate cancer screening, and others, but which are done usually out of the scope of primary care, such as premarital, pregnancy screening, and neonatal screening, and school health, and all. So now let's go, or let's revise what screening opportunities we can give to our patients for each age group. Starting from the pediatrics group, from birth till 12 years of age. So from birth, you should do, of course, the growth and development and the vision, hearing, and there are some important physical exams that you need to do, which are the hip exam for developmental dysplasia of the hip, and heart exam for murmurs and genitalia, and obesity screening. All these tests should be done at every visit, preferably every 3 to 6 months. At the age of 1 year, when they start to develop teeth, then every 6 months, they should do a dental checkup. And from age 2 to 3 years, I wanted to emphasize this, that you need to do a vision exam, which can be done even in your clinic, especially for amblyopia or lazy eye. This should be done every year. Why? Because amblyopia, as you know, is that one eye, because of a refractive error in one eye, the child depends mainly on one eye to have vision, and or on his vision, and the brain automatically cancels the vision in the defected eye. So if this is not caught early, before 5 years, then there's a chance that he will develop permanent damage in the affected eye. And usually, no one will detect it. The parents will not notice it, the child will not notice it, so you're the one who should pick it in your clinics. And then, at the age of 10 years, according to the ADA, you should start your diabetes screening for high-risk individuals, and I'm going to detail this in the next slide. So this should be, the diabetes screening should be every 3 years for children with high risk. I just wanted to remind you about the screening for developmental hip dysplasia. In the first 3 months, you can do the Barlow and Ortolani maneuvers, but after that, they're no longer valid, and you shouldn't do it. You should depend on either the finding of a limited abduction or apparent thigh length discrepancy, or something called the Klisic test, in which you place your hand on the greater trochanteric and anterior superior iliac spine, and then this line should be at the level of the umbilicus or above it. If it's below the umbilicus, then this may indicate that there's a developmental hip dysplasia. So if you find on clinical exam if you're suspecting DDH, then you will do a confirmatory test. The guidelines tell you not to do this routinely, the hip ultrasound for the first 4 to 6 months, or the pelvis X-ray after 4 to 6 months, unless the patient has a risk factor, which is breech or family history. Then you should go for the screening directly. The imaging directly. Again, to emphasize the screening for amblyopia, you can do vision exam in your clinic for the children for 2 to 3, starting 2 to 3 years if the child is cooperative, by Allen cards, which are cards that you can upload in your mobile or iPad, and from a distance of 3 meters, you can ask the child to cover one eye and test whether he sees them accurately. And then for older children, you can use the e-charts. This is the ADA guidelines for the screening of children from age of 10 years. They recommend that if your child is overweight or obese with one of these risk factors, maternal history of gestational diabetes, family history of type 2, race and ethnicity, of course, our race is a high-risk race, or signs of insulin resistance, you should do diabetes check. So for Kuwaiti population, any child who is obese or overweight, you should start screening him for diabetes from the age of 10 years. And the screening is similar to adults. You either use HbA1c or fasting blood sugar or the OGTT, and you need, of course, 2 readings, as you know, from the diabetes guidelines. So I find this guideline for the Well Baby Clinic very comprehensive. You can refer to it for further tests that need to be done in this age group. Now moving to the adolescents. So you will continue the things that you did in pediatrics, but here there's from the age of 12, a special emphasis on mental health screening should be done once a year. The obesity screening, it was every visit, now here once a year. And also you start to screen for substance abuse, including smoking, also as needed. At the puberty, you may screen for delayed puberty and STD screening. Again, there is a very comprehensive guidance from the primary healthcare department about the adolescent health. You can refer to it for further tests in adolescents. Now, we move to the young adults from age 18 to 39 years. So here we're specifying what tests should be done for both genders and what are tests that are for females and males. So starting 18, you should screen for obesity each year, and you should do BP exam screening for hypertension. This should be done every 3 to 5 years. And also you should start diabetes screening for high risk, and mental health screening once a year, skin cancer screening, and substance abuse once a year or as needed. In females, you should instruct the female to do a self-breast exam once a month, starting the age of 18. This is according to our guidance. Maybe some of the international guidance do not recommend that, but our guidance for mammogram screen or for breast cancer screening recommend that. And also for males, testicular self-exam and clinic once a month, and clinical testicular exam once a year. Again, the same age group, at the age of 20, you should start the breast cancer screening in your clinic. The lady should get a clinical breast exam every 3 years. And then at the age 25, this is the age where esophageal cancer screening should start with a pap smear for females, of course, every 3 years. And then at the age of 30, the clinical breast exam should be shifted instead of 3 years to 2 years. And here you might also screen people or ladies who have high risk of breast cancer every year by MRI, and I will mention them in the next slides. From the age of 35, all individuals, regardless of their risk, should start diabetes screening. And this should be done every 3 years, and if they're pre-diabetic, every year. So whom are what is the characteristics of women who are at higher risk and that you need to screen them earlier, before the age of 40? These are basically the ones who have genetic mutations or BRCA genes, or they have a strong family history of a genetic mutation. or who had a radiotherapy to the chest area, or the presence of these syndromes. So basically the one with a very strong family history or who are a carrier of the BRCA1 and BRCA2 gene mutation, they should be screened by MRI from the age of 25. For diabetes screening, this is the ADA recommendation, again, for all adults 18 and above. You should screen all obese or overweight or obese adults with one of these risk factors. And also you should screen all women who are diagnosed with gestational diabetes, all people with HIV, and all people with 35 years or above. Then the frequency of screening is every 3 years. Now moving to the next age group, 40 to 49 years. At age 40, you will start the breast cancer screening by mammogram, and it is recommended once a year for females. Also, for both genders, if the patient is at high risk, then you should do a BP exam every year instead of every 3 to 5 years. And here, the guidelines of ESC also recommend that you will start males only to screen them for dyslipidemia every 5 years. At the age of 45, both genders should receive the colon cancer screening, and of course by colonoscopy. This is the preferable method. It is done every 10 years, but if the patient chooses to do fecal occult blood, this should be done yearly, 3 samples every year. So the US Preventive Services Task Force recommend that for people who are 40 and above who have any of these risk factors, blood pressure in this range, or overweight and obese, or dark skin, then they should do, or the BP exam should be done annually for these people. If they don't have risk factor, then every 3 years. And of course, people with diabetes should have their BP checked at every visit. In colon cancer screening, usually we screen at the age of 45, but there are exceptions to screen earlier. What are these exceptions? If there's a family history of colon cancer or a documented advanced polyp, then you should perform the screening at 10 years younger than the age of the diagnosis of the first degree relative. Okay, so for example, if the relative is diagnosed at the age 40, then you should screen your patients from starting the age 30. And also another exception is the patients with inflammatory bowel disease who have ulcerative colitis or Crohn's disease. They should be screened for colorectal cancer 8 years after the disease or symptom onset. Also, the findings of the colonoscopy will determine your next colonoscopy screening. So the usual is every 10 years, but if you find if tubular adenoma were found in the first screening, and you know, of course, that tubular adenoma are precancerous, so depending on the number of these adenomas or the size, you might screen the patient earlier. So basically, if there are more than 3 adenomas or any adenoma with more than 1 centimeter in size, then the screening should be done every 3 to 5 years instead of every 10 years. We're moving now to the next age group. At the age of 50, here you will start prostate cancer screening for males, of course, using PSA plus or minus digital rectal exam, and this is done every 1 to 2 years depending on the PSA level. Here, in this age group, the cervical cancer will be done cancer screening will be done every 5 years instead of every 3 years. Also, you'll start here osteoporosis screening. Of course, you know how to screen by FRAX score. This is done every 5 years if the FRAX, if it was in the below the interventional threshold. If you decide to do a DEXA, then it should be every 3 years. And here, the guidelines tell you to start to screen women at the age of 50 for dyslipidemia every 5 years. And the screening for dyslipidemia for males changes to once a year. It was every 5 years in the 40s. Now it's recommended to be done every year. So we follow in Kuwait the European Association of Urology guidelines, which recommends to offer the PSA test to well-informed men. And I put well-informed in capital letters. It means that you really need to inform your patient about the pros and cons of this testing, since the prostate cancer is a very that disease that has a very favorable prognosis, and it takes a long time to progress or to advance. So if your patient has limited life expectancy, for example, he won't benefit much from screening. So usually above 50, starting from 50 years, but you might start screening at earlier ages if they have family history or if they have strong genetic mutations. Just to remind you that the PSA is different among different age groups. And usually when we request it in primary care, the level, they won't show us these ranges which are specific to each age. So you need to be aware of that. For a patient who is 50 years old, if the PSA is less than 2.5, then you can retest every 2 years. If it's above 2.5, you should do annual screening, and if it reaches 4, then you should refer for further testing. So 4 is the number that you're looking for in PSA screening. To continue, at the age of 50, also some guidelines recommend to do lung cancer screening for males using a low-dose lung CT scan every year. These are not all males, only those who are smokers or those with a smoking history. Also, some guidelines recommend coronary artery calcium scoring by CT scan every 10 years for both genders, and hearing test every 10 years. And from the age of 60, also you should do dementia and Alzheimer's screening once a year. These are the American Cancer Society guidelines recommendation for lung cancer screening. You start from the age 50 to 80, males, not females, who are either currently smoking or quit in the last 15 years, or have a 20-pack year smoking history. Now moving to the last age groups, which are 65 plus, you need to do all the previous, plus at the age of 65, of course, because they're now in the geriatric group, then you should remember the comprehensive geriatric assessment, like functional assessment, fall screening, vision and hearing and medication review. This should be done at every visit. And from the age 65 to 75, you can offer males, and this is also not in our guidelines or our screening manual, but some guidelines suggest to do screening for abdominal aortic aneurysm in men who have ever smoked by ultrasound. So this is done only once. So if you have smokers, men, then you can ask for ultrasound to screen for AA. What are the ages that you need to stop screening? Cervical cancer, you can stop screening at the age of 65, mammogram at the age of 70, colon cancer screening, you can stop at the age of 75, and lung cancer screening at the age of 80 years. Again, these two booklets from the primary healthcare departments are very helpful. This protocol, I depended mainly on my slides on this protocol for early detection of communicable diseases and cancers, and also you can go to the comprehensive geriatric assessment for the geriatric age population. I also wanted to remind you that in our electronic system, there's an icon for screening. When you click on it, all the screening programs will appear, and this red statement will appear according to the patient age. So they will remind you that it's time to do colon cancer and breast cancer for your patient if he's in the 40s. So my take-home message is, please offer targeted screening options to your patients based on their age and gender, and always it should be personal, informed choice, and involve your patient and explain the pros and cons of the screening well before offering. Thank you very much for listening.
Thank you, Dr. Yasmin, for your informative lectures. And now it's time for questions. We have a few questions. First one was about the clinical breast examination. It is the same as the self-breast examination?
No, self-breast is when the lady do it every month in her home. You just need to teach her how to do it. But the clinical, no, the proper clinical examination that you do for the breast in the clinic, and this should be done every 3 years for the younger, and every 2 years for those above 30 years old.
There is a question regarding the geriatric age group. They are asking about the comprehensive assessment and the aortic aneurysm, if it is done in Kuwait or not.
The comprehensive assessment, definitely, as my colleagues just mentioned, that in the geriatric age groups, and especially in the home visits and in the geriatric clinics, the abdominal aortic aneurysm is not done in the primary care, not very common in primary care, but it's recommended by many guidelines for males who are smokers.
Okay, thank you, Dr. Yasmin.
We'd like to thank our moderators, Dr. Sara Al-Abdelhadi, Dr. Dalia Al-Mirjan, دكتورة منى المطيري، And with this, we conclude our lectures for today. For those who registered for today's workshops, they'll start at 3:45. And for the rest, we'll see you tomorrow, inshallah.